starting the clock, and if you could call the meeting to order, I will do roll and do the land acknowledgement.
Yes, I'd like to call the Health Commission Community and Public Health Committee meeting for January 18th to order, please.
Great, and I will call roll. Commissioner Gerardo.
Here.
Commissioner Chow.
Present.
And I will note when Commissioner Chung arrives, I know she's planning on attending. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Commissioner, is it okay if I call the items on the agenda, or would you prefer to do that?
No, please do, Mark. And I assume we may need to wait for Commissioner Chung for the approval of the minutes for item 2?
We can move ahead even though Commissioner Chow wasn't here, but if you prefer, we can do that at the end when Commissioner Chung is here. Would you?
Why don't we do that?
Okay. Of course, yes, great. So we can move on to item 3, which is the San Francisco Health Network primary care update, and I will share my screen with the presentation. Give me a second.
And while you're pulling that up, Mark and commissioners, if I could just introduce our speaker today, our presenter, whom I think not everybody has met. Dr. Anna Robert is our Director of Primary Care for the San Francisco Health Network, DPH. And we'll have a chance, I hope, in the coming months to recognize the work of Dr. Robert and her team during the COVID pandemic and their work to really address health disparities, especially as they disproportionately impacted different communities and our patients who we serve in primary care. Anna is going to present to you an overview of primary care and then go into some detail on some of the COVID-related work. But their work is really expansive, and they've been able to maintain that during COVID, as well as be really leaders in community responsive work to mitigate the impact of COVID on the communities we serve. So it's an honor to introduce Anna Robert and her team.
Thank you, Hallie. Thank you, commissioners, for having us today. We're trying to get Blake Gregory. She was going to help do part of this presentation today. Mark, I don't know if there's any tricks for getting her into as a presenter.
Sure, I can move her. I can move the folks in the line over. Just for you know, once I start sharing, I can't see anything. It's a weird setup. Is Chloe also part of your team?
No.
Okay, then I'll make these two. There we go.
Yeah, great.
Is it okay to start sharing?
Yep.
Okay.
Yes. And last year, around this time, I think we presented, it was a very somber presentation, I remember, just about like just the profound impact that the pandemic has had on our system and our patients. And we're really excited to be here today to share with you the progress that we've made in the last year. We got your list of questions. We'll try and address them as best we can throughout the presentation. So thank you for sending those over. Next slide, Mark. Just a reminder of where primary care sits within DPH. We're under Roland Pickens with the Health Network. And Dr. Hallie Hamber is the Director of Ambulatory Care, and we are one of her divisions. Next slide. And this is our primary care vision, which I think you're probably used to seeing by now. It's been our vision for several years now, and really are continuing to strive to be the first choice of healthcare and well-being. And still focused on our 6 pillars of safety, quality, care experience, people development, financial stewardship, and equity. Next slide. And our clinic distribution across San Francisco, as you can see, we're in all 4 quadrants, but mostly on the east part of the city, both the north and the southeast sides of San Francisco. There was a question around the 4 youth clinics, and Carol Taniguchi, who's our deputy director, used to be the director of our community health programs for youth, is here just to give a quick little overview of the 4 different sites.
Yeah, thanks, Anna, and good afternoon to commissioners. The school-based, so we have the youth programs encompasses, over 10 sites, and special programs for youth is the clinic up at Youth Guidance Center up at the Juvenile Justice Center, and we provide medical services up there to detained youth. And then we have a few school-based health centers, of which Balboa Teen Health Center is one of, and predominantly focuses on school-based health, mostly family planning, and then some urgent care services. And as of late, we've been doing a lot of sports physicals for youth in schools trying to participate in school sports. And then we have a clinic over in the Tenderloin with the Larkin Street Youth Center, and that partners with Larkin Street Youth Services. It's a very collaborative partnership for youth mostly experiencing homelessness in the Tenderloin. And then we partner with Huckleberry Youth Services in the Haight-Ashbury, in our Cole Street Clinic, mostly focusing again on homeless youth, but also we do get quite a bit of high school students and college students that access that clinic there. Also, and then New Generation Health Center right across the street, sort of kitty corner to the hospital, is a center that does a lot of women's health and young person's health. We actually at that site see up to age 30. And then we have a couple specialty clinics that aren't quite listed on here, but we do also have Dimensions Clinic, which serves our LGBTQIQ population. And then we have a Kara-sen, a second chance tattoo removal program that we operate in the community and the mission.
And then the 2 additional school-based sites that aren't on here are Willie Brown Middle School and Burton High School as well. I misspoke and said 4 sites. I'm not certain. I'm just my nerves here. So thank you, Carol. Next slide, Mark. And overview of who our patients are. There is a question around the number of enrolled and not yet active patients. And why that number is so high. So this number has been steadily increasing. You'll see in the next slide, I think, or maybe 2 slides down, you can see that our overall empanelment, the number of patients that belong to our system, have steadily increased, specifically since COVID. A lot of the reason for this is because with the pandemic, the requirement for people to do an annual renewal of their Medi-Cal was removed. And so people have been continuously enrolled in Medi-Cal during this time. I think that the latest I have heard is that this was going to go back to an annual renewal requirement starting in January. So we'll have to see how the numbers play out with that. It's actually very wonderful for our patients and our system to not have a break in enrollment and have to go through the hassle of renewing. So I'll just throw out my advocacy there in support of those rule changes that were made in response to the pandemic. And I know there was a question around vitamin D deficiency and sort of our approach to that or not. Blake, did you want to say a few things about that?
Sure, it's a great and an astute question. And a vitamin D deficiency, I think there is some component of it that's nutritional, but it's actually largely related to sunlight exposure. And so in terms of why this figure is so high, we it's a very routine thing to check vitamin D deficiency. When we drill down and look, it appears that the predominance of that population that's vitamin D deficient are Asian patients who are over the age of 50, just in terms of our demographics. And so, part of it has to do with the fact that vitamin D deficiency is incredibly common, across the population at large. But also, if there are, for whatever pieces related to nutritional deficiencies, we have been doing a number of pilots with an organization called Eat SF to provide free food vouchers for fresh produce for a number of our patients. And this is one way that we are trying to address food insecurity, which is very common in our patients, and it's been exacerbated by the pandemic. So we're very aware of food insecurity as an issue that affects our patients, and we have some really exciting projects in the pipeline to try to help mitigate that.
Thank you, Blake. Next slide. And then with that, well, I'll just speak a little bit more to our enrolled but not yet seen patients. Is that historically we have always had that, when people sign up for Medi-Cal, they have coverage, and then they typically choose which medical provider they want to be with. And people who are more engaged in their healthcare, have a more immediate need for healthcare, are generally more active in selecting exactly where they want to go, so that they can, whether it's where they currently seek care or where they know they want to go because they have active health issues that are ongoing. And there was a rule or law passed that for patients who are enrolled in Medi-Cal but don't choose a medical home, it used to be up to 75% of those people would automatically get assigned to the local health departments. This is across California. And so we would get a lot of patients assigned to us who filled out paperwork somewhere along the line to get signed up for Medi-Cal, may not have a reason to access it. And so we've carried, quite a large panel over this time of people who are not engaged in care. We've tried various things over the years of trying to bring those people in, and continue to work on that, and recognize, especially as some of our waiver programs, our QIP in particular, that we are responsible for ensuring even patients who are assigned to us, that they are also up to date on all their healthcare maintenance needs, even if they're not directly interacting with us on a regular basis. So we will be likely looking at that more closely as things sort of stabilize for us, and we're really opened up for business as usual, although I don't think there'll ever be business as usual again. But anyway, you can see pretty impactful, the red line in particular, of our number of enrollees who have increased since the start of the pandemic, and happy to be there for them and really serve our communities. Next slide, I'm going to hand it over to Blake for the remainder of the presentation until questions.
Thanks, Anna. And so I'm going to spend the next few minutes just kind of giving you an overview about what we're doing in primary care now that we're 2 years into a global pandemic. And apologies for the busy slide here, but there are just a few things that I want to highlight. So this is a graph that starts when we went live with Epic in August 2019 and goes all the way to October of this past year. If you look at the top part of the graph, that top line shows you the number of visits that we are doing month by month. And I think what you can see is, over this time period, our visit volumes have continued to go up and up and up and up over time. And so we're very busy, we're very productive, we're seeing a lot of patients. Because of shelter in place, this is now a mix of telehealth and office visits. Great that we can provide telehealth services to our patients. It's very convenient for them. But this is all to say that we're very busy and we're seeing a lot of patients. We love that, and that's what we want to do. The other thing that I want to highlight here is these yellow, blue, and red lines represent some of our routine healthcare preventative services that we provide. So diabetes testing, mammography, and colon cancer testing are what these lines represent. And I think you can also see that, of course, with shelter in place in March of 2020, all of those numbers plummeted because we were all just trying to figure out how to mitigate the COVID outbreak. But since March of 2020, these numbers just keep getting higher and higher and higher. And so hopefully this kind of hits home at the point that we're busier than ever. We're doing as many healthcare preventative services, actually more healthcare preventative services than we ever did before. And so all of this is to really highlight the work that is happening at the level of primary care to serve our patients. Next slide, please. And again, this is a little bit of more of the same, but our mission over the past year or year and a half is really how can we get back to the basics of what we do, the foundational work of keeping people healthy despite the chaos of this pandemic that we're in. And so again, this is a busy slide and I apologize for that. But if you look at this line graph at the bottom, what I really want to draw attention to is the fact that all of these slopes, almost all of them are continuing to rise. In other words, our rates for cancer screening, for tobacco counseling, for screening for depression, all of those things are going up and up and up. And I hope this kind of helps highlight the true efforts of to recover that we're trying to make, just to get back to the foundational work that's so important to us and to our patients. And there were a couple of questions about behavioral health vital signs, so I'll just comment on that briefly. Behavioral health vital signs includes universal screening for depression, substance use disorders, alcohol use disorders, and intimate partner violence. And really our goal is to screen every patient once a year. And so as you can imagine, with shelter in place that fell off, kind of all of our standard work kind of fell by the wayside. But this past year, we've been making really, really concerted efforts to recover. And so, at this point, we've screened half of our population for behavioral health vital signs, and we want to keep seeing that number climbing. And there was another question about screening and brief intervention and referral to treatment. I will flag this as a metric that needs a little bit of work, but this metric basically looks at patients who screen positive for alcohol use or drug use and whether they were referred to a behavioral health specialist. These numbers look low, and they're probably very falsely low because there are many other ways that we can intervene for a patient who has drug or alcohol use problems besides making an actual referral. So we may physically walk them over to a behavioralist, which wouldn't count for this metric, or we may offer them medication-assisted treatment, or other things that are not captured in this metric. So I appreciate the question here, but this metric I don't think quite represents all the work that's going on with drug and alcohol use interventions. Next slide, please. And this is just a slide speaking to our data collection around screening for gender identity. And so this is just on the top left is a breakdown. About 52% of our patients identify as female, 45% is male, and then smaller buckets for transgender female, folks who choose not to disclose, non-binary, and so forth. But this just kind of gives you a representation of, where our patients are in terms of their gender identification. And then we've been doing a very concerted push to try to just improve our data collection. And so we've set a goal of capturing data, SOGI data, on at least 80% of our patients who are coming in for visits. And as of January 6th, I'm proud to report that we are hitting that number. So the data is really important, and we've been doing a lot of work to try to up that collection so that we can better understand our patients. Next slide. And now I want to talk about some of our COVID vaccine and testing work. This has been at the core of what we've been, doing for the past 2 years. But we have, 16 sites throughout the city that are vaccinating patients. Our sites are located in the communities that are most impacted by COVID. And, we're not just vaccinating our patients, we're vaccinating the entire community. So only about a third of those vaccinated at our sites are even our patients. And the other 2/3 are not our patients, but many of these folks are from underserved communities. And I'll show you a map in just a moment to represent that. And then the other thing I'll say is that, while we are responsible for the care of less than 10% of people in San Francisco, we have vaccinated more than 20% of residents in San Francisco. So all this is to say, we're here for the community. We want to keep our patients and everybody else in the community safe. And then as of last week, we had administered over 284,000 doses of vaccine, and we're going at a clip of 834 vaccine doses per day as of last week. Next slide. And this is just to let you know how we're communicating with patients, because the vaccine initiative has been very confusing, hard to keep track of, even for me, much less our patients as the guidelines change. And so over the course of the past year, we've sent out 175,000 text messages, 85,000 emails, 60,000 messages through the patient portal, 125,000 snail mail letters, and we have also made 10,000 live outreach calls. It's really hard to hard to describe how many person hours this involves to call 10,000 people, but we've done it. And then we've also done a lot of partnership with organizations in the community to do the following. We have made sure that providers are available in person for many vaccine events to answer questions. This is a program called Ask an Expert campaign. We are distributing flyers, and here are some examples here on the right in many different languages. We have been partnering to provide transportation for patients to get to our vaccine sites. And then we've hosted a number of vaccine webinars for patients who have questions, understandably, about the vaccine. Next slide, please. And this is a program I'm really proud of that I want to share with you. So starting in February 2021, so just about a month after vaccines became available, we were one of the first programs in the country to start vaccinating patients in their home. And so this is part of a team of nurses that goes out and provides vaccine services not only to our patients, but anybody else in the household who wants it. And not only do they vaccinate for COVID, they vaccinate for flu, again, for anybody in the home who wants it. To date, we've vaccinated over 300 patients. And if you could advance it one. And this is just a story that I wanted to share that I find really touching. This is about one of our patients who's a Black African-American woman, 97 years old. She's cognitively impaired, homebound. She goes to Southeast Health Center for her medical care. And I had a wonderful conversation with her son, who's her caregiver. And he shared this story that, when he found out his mom could get vaccinated in the comfort of her home, he said, I felt so good in my spirit about it. The nurse answered all the questions I had without breaking a sweat. It was a blessing. And he said, we are so grateful. You guys are angels. So this is just a really wonderful program and something that we are continuing to offer to patients now, not only for their first doses, but also for their boosters. Next slide. And then this is just a map representing who we're vaccinating. And so I mentioned a few slides ago that only about a third of the patients we're vaccinating are San Francisco Health Network patients. But the remainder live in largely, low-income communities and communities of color. And so this map on the left here shows you the prevalence of COVID-19, and you can see it's mostly affecting, case rates are mostly affecting people in the southeast part of the city. And then you can also see that's where we're vaccinating. Those are the darker areas here where we are administering the most vaccines. And so hopefully you can see the overlap between COVID case rates and the people who are getting vaccinated. In other words, the people who need it most. Next slide. And in terms of who we're vaccinating, we collect data weekly and disseminate it about how we're vaccinating by race and ethnicity. It's well known that there are stark disparities in vaccination rates, particularly for people of color. And so while we do better than a lot of other places with vaccinating people of color, there are disparities. And so I have this red arrow highlighting that for folks age 12 and over, our Black African Americans have the lowest rate of vaccination. And then that trend is also similar for ages 5 to 11. And so this is something that concerns us. It's something we talk about all the time, where we've deployed a lot of countermeasures to try to drive up our vaccine rates for these populations. And I'll talk about that more in the next slide if you can advance. And so this is one intervention that we've used to try to better understand the disparities in vaccination rates that we're seeing. And it really all starts with data. So one thing that we found in our explorations is that there is a small but very real disparity in documenting vaccine offers to Black African American patients. And so that's what this slide at the bottom shows you, is that there's between 2 percentage point and 5 percentage point disparity between documenting that a provider offered the COVID vaccine to a Black patient compared to the general population. And so this is something, again, we never want to see this. We want the disparity to be zero. And so we have done, staff trainings. We're in the process of putting on more trainings. We're freely sharing this data on a weekly basis. We're having conversations with our management teams about it. We've been doing live outreach calls. We put on webinars, and we're still doing this Ask an Expert program at vaccine events. And all of this is just to try to shrink the disparities that we're seeing. So lots of work going on around this. Next slide. And then the last piece is just about COVID testing. As you know, we're in the middle of a surge with Omicron. And so this slide here just kind of tracks our testing numbers starting from the very beginning of the pandemic. And you can see a large peak in January of 2021, another smaller peak with the Delta variant in August and September. And then, this last bar here on the right shows the month of January as of January 10th. And so this doesn't look tall, but it's only about a third of the way through the month. So I think we are going to see these numbers get higher and higher as we go through the month. Our test positivity rate is a lot higher than it was even in November. And so this is something we track very closely. But just to say that, with our testing sites, we provide services to the entire community. It's not just our patients. Any SF resident can drop in, no online scheduling required, and they can be tested. And then we make sure that anybody who gets tested at our site gets a phone call and gets notified about any positive result. And so we have a really robust process for that. Next slide. And then just to wrap up, our priorities for the upcoming year, we continue to focus on, healthcare disparities for our communities of color, and moving forward with an anti-racism and equity action plan. Population health is a big focus of ours, and we continue to improve every single month with our healthcare maintenance numbers, as you saw. But there's still work to do. So we're pushing ahead with that. We're going to be focusing on access to care so our patients can see us when they need to. And then also, taking care of our own primary care teams who are overwhelmed and burned out and just stretched to their max. And so thinking about how we can continue to support them in staying resilient during these really challenging times. And that's all that we have.
Yeah, and just to say thank you so much, Blake, and want to recognize all the other team members that are on the call with us today. It's all of these efforts are dependent on every single person on our leadership team and our local management teams. So just huge amounts of gratitude to our core central team that's here with us today, and also our local management teams as well.
Thank you.
I think we went over our 15 minutes. But.
Oh, that's all right. Thank you so much for caring and for the great presentation. Before we go to commissioner questions, I'm going to check the public comment line to make sure there's nothing there. Folks on the line, if you'd like to make comment on this presentation, which is item 3, please press *3 to raise your hand so we can acknowledge you. *3. All right, commissioners, I don't see any hands. So Commissioner Gerardo, I do see your hand, so please ask your questions.
Thank you. Thank you for this excellent presentation. It's one that I'm very, very interested in, and you've been doing just a wonderful job in very challenging times. And I appreciate the answers to my questions. I had one more question, which is what is the percentage of the primary care clinics that have integrated behavioral health within the clinic? And what is the structure within the clinic?
Yes. So Hamilton, I can go ahead and answer this if you want. Hamilton is our interim director of primary care behavioral health. Are you there, Hamilton? Just for oh, you can't. Having audio issues. Okay. So all of our clinics do have integrated primary care behavioral health. The general structure is that there are behavioral assistants that are focused on providing access to services and care that are sort of more social determinants of health driven. So access to food, transportation, they need help getting medical equipment, things like that. And then we do have every site does have on-site either LCSWs, licensed clinical social workers, or MFTs available for warm handoff if someone is needing that warm handoff, or referral for patients who screen positive for you have a PHQ, elevated PHQ-9, IPV, anxiety. Oh gosh, there's one more, but they're all there located. With the co-located, and with the caveat, I think, and you've probably heard this, like much of DPH, where we continue to struggle with vacancies, and in particular with behavioral health clinicians. It's not unique to our system. It's a nationwide crisis, really, that we're in right now. And so just to say that we do acknowledge that some of our sites do not have all of their positions filled, and so it is sometimes a bit of a struggle, and our primary care providers end up caring and treating for patients that ideally we would be able to hand off to a behavioral health clinician. And then also to say we do have a team of psychiatrists that are available for intakes, referrals, and consultations with providers. And then we have 4 primary care homes. We call them integrated behavioral health homes, where we have primary care providers that go to the specialty behavioral health clinics. There's one in Chinatown North Beach, south of Market, Sunset Mental Health, and Mission Mental Health, where we have a team of primary care providers that go out and they provide primary care in the behavioral health home, sort of a reverse integration for several patients.
Thank you. I've just understood from in my practice, et cetera, just, the frustration with the access because of so many people right now, particularly trying to access behavioral health services, and a limited number of clinicians. In the primary care clinic that, with the LCSW or MFT, do you do in the warm handoff and like limited 4 or 5 sessions if there is no access, or the referral is, yes, we will take your referral, but our next time is in 2 months, and you've got a PHQ-9 that's very high for depression or anxiety?
Dr.
What is
Holt,
that?
I've unmuted Dr. Holt, who might be able to answer some of this.
Oh. It doesn't look like. So it doesn't look like we can hear you, Hamilton. No. So that it's an ongoing challenge for sure. We're trying to do our best to keep to make sure that people aren't waiting for weeks on end. There's been a lot of cross coverage across the clinics using as much as we can using behavioral health clinicians to cover other sites as needed. And then also we are able to refer people who are beacon providers to seek care outside of our primary care home. So we also do take advantage of referring people to other locations if we're not going to be able to get to them in a timely way.
Okay, no, thank you. And I understand and know the frustration because I know our Child Development Center, we've got this exact same issues.
Right, thank you, Commissioner. And I'm sorry, Dr. Holt, you're unmuted, but maybe the mic isn't working. I see Commissioner Chung's hand.
Thank you, Mark, and thank you for the wonderful presentations. And I really would like to say how much I appreciate the personal stories because it actually humanized the patients that we serve and also highlight, their experience and, and how they value these relationships. So thank you so much. And I am hoping that, other presentations will also include this element because we don't get to be in contact with patients as much as the providers. So we know the provider stories, but we want to know like how patients are seeing the work that you all do. And so I appreciate that very much. I just want to say that.
Thank you.
Commissioner Chow, any questions before we move? Oh, yes, I see your hand. There we go.
Yes. Can you hear me now? Right. I had several, in addition to thank you for answering about the vitamin D, and we can come back to that, but I thought I'd just go in the order of your presentation, and thank you so much for all the work that you've been doing. And it's wonderful to see the primary care visits and all have come back, and also that we're able to continue to provide telehealth. Although I guess most of it is audio rather than actual video, right? But so these are kind of questions just to say that as we get back into a norm, I know that you have Balboa as a high school, and you've mentioned that you have several other schools that have had it, and I guess maybe they're grammar schools or junior highs. I'm not quite sure. But I do remember that when we had our meeting in the Richmond, Washington High School seemed to feel that they really appreciated the mental health services. And I don't know if we have anything like that, or for some of our other high schools, are there plans that that our San Francisco Health Network will then be staffing or working with the school district to have more ready access for the particularly the high school kids, who I think really feel sometimes very much a need for help and support.
Carol, you want to speak to that?
Sure. I will just say that, through our CBHS partners, we do have behavioral health services in all the high schools and middle schools, and so through RAMS. But in terms of medical services, we have the two high school, Balboa and Burton High, and then Willie Brown is a middle school. And then we are actually piloting, we had a pilot pre-COVID at Ida B. Wells, and it went really well. So we were piloting what we're sort of calling a pop-up clinic, where we're not there every single day, but we schedule to be there at least once a week, and we work really closely with the wellness centers and the high schools. And we are reinvigorating that process because many high schools, including Washington and Mission, have reached out in Downtown High, and they all have wanted some semblance of being able to offer on-site medical and family planning services to their students. So that is in the works right now.
Great. Just wanted to hear that we were continuing to move in that and expanding our services, and so happy to hear that RAMS and the mental health services are in all of our facilities, because that's really progress in these years. On the vitamin D deficiency, I was not quite clear if we're saying that they were Asian adults. it's probably not necessarily a question of sunshine, right? Not that we don't have a lot, but a lot of these people don't really get a lot of sunshine. But what is the treatment for that? I thought most of those actually might have been younger people, but now that you say that, and it's great to break out the demographics. So is there something specific within the Asian community or the Asian diets that you're looking at, or?
That's a very good question. Yeah, I don't have a ton of expertise in this area. You know, I'm just looking at the demographic data that we do have. It's about 25% of our patients with vitamin D deficiency are Asian, and of those, it appears to be an older cohort, age 50 and above. And you're right that you know, it's probably, you know, partly a reflection of just, yeah, not getting outside. You know, these folks may work really long hours during the day, or they may, you know, have the sort of living conditions where they don't have very walkable neighborhoods. And so I think there are a lot of possible explanations. I also, you know, I'll have to dive deeper into this, but I'm not even sure like how this vitamin D deficiency maps to the population at large, because it's very common, I think, across all demographics. And so that's not something that I kind of have handy right now. Is, you know, are we dramatically more deficient in our population compared to the larger population across the country? I'm not sure about that. But these are all things that I'm happy to take a look at.
No, I think that's great, and you're exactly right. I've been very surprised in the last year or two that there's so much more literature on vitamin D deficiency, when we've all thought it had gone away, either with milk or, of course, in the Asians, there is more lactose intolerance, right, as you get older, and that may also be another reason for people dropping, you know, taking milk and it would be interesting for you as you're looking at that and looking at the cohorts to see if we would get specific types of remedies that would then, you know, target what the what your findings are. But I think this is another great example of the disaggregation of data, and allows us really then to focus. I mean, if a quarter of these people are within the older Asian group, there's an opportunity there.
Yeah,
That we
absolutely.
weren't just saying we just you know, looked across the board and thought they were probably kids or something like that. But
Agreed.
so I think that's really good. As you were looking, I was looking at the getting back to basics, and I think it's a wonderful, if very laden with data charts. So want to again thank you. I think we've really built a lot more data into our delivery system here, and probably Dr. Hammer has been one of the people that have helped greatly. But I really appreciate that now we're looking at data. I know that your report cards have looked at it. It would be helpful. I know this was just designed to show what we were doing in COVID and where we're getting back to. I'm pretty sure your scorecards at the other end do show the goals that you will have. And so I just leave it at that. This is helping to demonstrate we're getting back to our preventive services, but then question then arises, are we going to be satisfied with the colorectal cancer screening of only 50%, right? Where nationally we're really at 70%. So, but I know you have those goals. So I just wanted to again commend you for all the data that you're able to give us in showing that our systems are starting to get back to some sort of norm. I think lastly, by the way, I want to commend you. When that home vaccination came out, I thought, boy, this was really wonderful, and we can all be proud that we have a department that really thinks that way, and not make everybody come down to the clinics, because many of us know, and we've had that challenge in trying to take care of our elderly. How do we do that? And some of us were making house calls in those days. And now I think, you know, part of the challenge of care coordination is how do we get back into the homes and see what's going on. So this was so great that you were, you know, giving COVID to the entire family. Not giving COVID, giving the vaccine to the entire family. However, I was a little surprised, and now that you've explained the addressing disparities in vaccination chart, which was not actually easy to understand, but having understood what you were saying, I am concerned that in Chinatown, we have such a very low rate of apparently asking the number of African American patients whether or not they should be, offer. Well, I'm not sure if that's offering the vaccine or making vaccine information available.
So, like, do you want me to take that?
Either way is fine.
Yeah. So, I mean, so if you look closely at the chart, part of it is, so it's offering, documenting either deferring the vaccine or offering it or scheduling an appointment for the person to get a vaccine, or they completed a vaccine within a week after, um, within a week of the visit. So it's a little complicated, but I think sometimes Chinatown does very good. If you look on the data that's there, they had 2 Black patients who came in that week, and it looks like 1 did not have documented discussion. So I think the data is a little bit. I mean, we want to make sure that we aren't missing any opportunity at all. So we are still discussing this, even with Chinatown that has a but that has mostly, they don't have a very large Black African American population. We're still making sure that we're addressing it across the board. But
No, thank you for that explanation.
yeah,
And makes me feel a little better that
yeah,
they were not ignoring the population in a large block, but that these are smaller numbers. And
Yeah.
appreciate that this is data you can work on and act on, but that we shouldn't take it as being a norm. Thank you.
Yeah.
And I appreciate the opportunity, Madam Chair, to be able to ask questions. Thank you.
And Commissioners, if I may, Dr. Holt was unable to speak earlier, but he wrote this in the chat. We have 5 out of 12 clinics with full staffing for behavioral health. This addresses your question, Commissioner Gerardo. Appointments are addressed if increasing urgency. Our primary care behavioral health director position has been vacant since 2020. We have a highly qualified person, and it's currently snagged in HR. And he asked for advocacy to help get that through. But probably the next time you all hear an update, that hopefully that position will be filled and you all can continue to get more data. But I wanted to make sure that you heard that. Are there any other questions, commissioners, before we move on? And thank you, Dr. Holt. All right, Dr. Chow?
No.
Okay,
So, I was
great.
trying to remove it.
All right, I'm not forgetting the minutes, but I thought out of respect for the next presenters, we'll do the minutes after the next presentation. So let's move on to item 4, which is the San Francisco Retail Tobacco Permit Enforcement. And I will share my screen. Give me 1 second.
Good afternoon, Commissioners. I am Janine Young. I'm one of the senior health inspectors at the Environmental Health Branch. And I'm here with the program manager, Jennifer Calloway. She's in the background. And we're both here to share an update of our retail tobacco program and some of our enforcement. Can you do next slide, please? So we're going to just do a short overview of the laws that pass and talk about the permit density and map, a tool that our public can use, some of our enforcement processes and some of the stories from the field, and talk about our current and future program goals. Next slide, please. So San Francisco began permitting tobacco establishments in 2004. And since then, there's been about 8 laws that have passed. from like no tobacco product sales in vending machines, no tobacco product sales in any store with a pharmacy. And 2015, we passed the tobacco density law, which has a cap of active permits in the supervisor districts of 45. And then we passed a flavor tobacco ban in 2017 and e-cigarette restriction. If you don't have your FDA pre-market approval, you cannot sell that e-cigarette in San Francisco. And then we also have a ban on the distribution and online sales of flavor products in those restricted e-cigarettes. Next slide, please. So it seems like San Francisco has passed a lot of laws, but it really is because of the staggering numbers of youth access. In 2021, for example, data was released that over 20% of our San Francisco high school students had ever used tobacco products, and 65.2% of our California students tried vaping. And all of these students stated that it was very easy to access these products. And next. And then go to the next slide, please. So one of the laws that San Francisco passed and tried to prevent youth access was density. Density set a cap of 45 for active permits in all the supervisory districts. In 2014, when the density law was passed, we only had one supervisory district that was below 45. Now in 2022, we have 5 districts that are below 45. Next slide, please. And then here's a map that charts that shows that at the beginning of the density law, that we started off with about 923 permits, and we are all the way down. This slide says 635, but we have an updated number for October 21, which we are at 621 total active tobacco permits in San Francisco. Next slide, please. And this slide is showing you the active tobacco permits by supervisory district. So as you can see, 45, I know it gets a little crowded down there because our permits are dropping in each supervisory district. But you can see at the 45, which is the cap, we have supervisory districts 1, 2, 4, 7, and 11 that are currently below the 45 cap. And then we have supervisory districts 3, 5, 6, 8, 9, and 10 that are above the 45 cap. Next slide, please. Now, one of the tools, because it was very important that we wanted to be transparent and to make sure that our establishments were aware of how density could affect affect the permit when the business was sold to another person. We collaborated with the San Francisco Planning Department and created this density map. So all you have to do is click on the website, type in the address, and then a map will let you know whether or not that location could obtain a SFDPH tobacco permit. Next slide, please. Now I wanted to talk a little bit about our enforcement process, because our enforcement is also a collaborative effort. So for example, we have Tobacco 21 enforcement, which is a collaboration with the San Francisco Police Department. I will give you an example. Today I went to a business that sold to a San Francisco Police Department decoy minor. The minor was 15 years old. When I approached the business was currently facing a 20-day suspension of their tobacco permit. But with our enforcement process for first-time violators, we work with them. We provide our establishment to have an opportunity to reduce their suspension period by implementing strategic tools. So for example, this business is going to retrain their cashiers, and for that retraining, they will have 5 days reduced from their suspension period. They will also relocate all of their tobacco products so that it's not visible to anyone, and they will receive another 10-day reduction. So instead of looking at 20-day suspension, that business is partnering with us, implementing strategies to prevent future sales to a minor, and will serve only 5-day suspension of their tobacco permit. Next slide, please. When we passed the flavors law, we learned from our businesses that it was very important to them that the department had a strategy for first-time violators. So similar to the Tobacco 21 enforcement process, we implemented an opportunity for first-time violators to not serve a suspension period if they sold flavors or if they sold restricted e-cigarettes. So for the flavors and restricted e-cigarette products, we provide a 72-hour window to allow them to remove those products from the establishment, and they will not serve a suspension period. Next slide. And now I would like to share with you a couple of case stories so you can see how our enforcement process, our work with our businesses to allow first-time violators to have an opportunity to correct the violation instead of a suspension is working. So my first case is a business where a food inspector was conducting a compliance inspection, and that food inspector contacted me because they saw flavor products at the establishment. So I went out to the field with another inspector. Next slide. We arrived about 30 minutes after the phone call, and when we looked into the establishment, we couldn't find any tobacco products. We found areas where we thought that had something there, but it was nothing there. And we looked everywhere. We looked in the backyard, we looked in the storage bin that was also located in the backyard. And so what I did was I spoke to the manager and I said, please let us know where the tobacco products are. So we are going to give you 72 hours to have all those products removed from this establishment. When I told the manager that, next slide, please, they led us to where they had relocated the tobacco products. It was actually located on an adjacent property. Next slide, please. And there were lots of tobacco products. There were menthol products. There were products that had alcohol flavor, honey, sweet, spice, and they revealed everything to us. Next slide, please. Now with the distribution law, next slide, please. I went to do a compliance check at a business and found flavor products again. When I spoke to the manager informed me that the products were shipped and showed me the invoice. And as I was looking at the invoice, the manager said that the shipment was that morning. and that the truck that shipped the products was outside. So I took my camera, next slide please, and found there was the truck. And I spoke to the truck. We got the information about the company. We contacted the company directly and issued them a notice of correction. And that company called us back and made sure that they would not ship flavored tobacco products to any of their clients in San Francisco. So in both cases, having that opportunity for first-time violators not to have strongly penalized, but to really work with us is working. Next slide, please. One of our challenges is that the products out in the field are changing. It's getting more and more difficult for our retailers to know what's a flavor, and even our vendors aren't aware that these products are flavored. So we wanted to share with you an example of products that are labeled as tobacco-free nicotine products. The labels are big, tobacco-free nicotine, and we have been finding these flavored tobacco-free nicotine on the shelves because the retailer and the vendors are not aware that these are flavored e-cigarette products. So it's making it very challenging out in the field. Next slide, please. And what we are finding is that our outreach, our compliance checks, and our enforcement, we're still finding products on the shelves. And we decided that our next step is to start partnering with our community. So we are excited to announce that we are partnering with the San Francisco Unified School District so that we can support them in their work of tobacco use prevention at the youth level. And we are also partnering with community organizations so that we can work with the community to really come up with some creative, innovative ways of monitoring and preventing these products from even returning to the shelf to begin with. Next slide, please. So one of the last things I wanted to share with you, as we face a lot of the challenges of these new products and new ways that the tobacco companies are misleading our retailers and our vendors and distributors, we were putting a lot of pressure on ourselves, that sometimes we felt that we were just chasing our tails, just going round and round in circles. And we had a meeting, and at the meeting was one of the San Francisco deputy city attorney. And that city attorney said, hey, look, at the big picture, at least 90% of the products are off the shelf. And just by that statement, it released a lot of burden that we were placing on ourselves, that we are really doing some great work. We are working with our community, our vendors, distributors, to really make sure that these flavor products are not accessible to our youth. Next slide. And if you have any questions, Jennifer and I are here to answer them. Thank you.
Thank you so much, Ms. Young. I'm going to check with the folks on the line to see if anybody has public comment on this item, which is item 4. If you do, please press *3 to raise your hand so we can acknowledge you. So you can make comment. Again, *3 for those on the line if you'd like to make public comment. It's hard for me to see, that's why I'm staring at the... Okay, I don't see any hands. I see several commissioners' hands. All right, Commissioner Gerardo.
Thank you for the very informative presentation. And I appreciated the history as well from 2004 going forward. One of my questions, though, as you had mentioned, is that you know, there still are the flavored tobaccos, and vaping is still very big in the high school with the high school kids. And I am wondering, in your partnership with SFUSD, since I know DPH always has had very clever marketing or education tools, that I'm hoping and that there would be an educational, creative, you know, um, very, you know, catchy uh, education about vaping. I, as a psychologist, see a lot of teens, and vaping is still very big, and they all know where they can get flavored tobacco and et cetera, et cetera. But I'm just wondering if in that partnership, you might be able to kind of push more on, uh, like I said, a catchy education about vaping, specifically vaping, because that's what the preference is.
Yes, we agree with you, Commissioner. We are going to be working with the San Francisco School District. We know that the Tobacco Prevention Youth uh, an education program involves the youth, which is really exciting. And they have already created campaigns around vaping and flavored tobacco products. So I think uh, when we get more into the work, they will be able to come back with you to see. We're excited too. We're excited to see what the youth are doing and how the youth, even the language that the youth have for each other. So we would like to, perhaps be able to come back and share that with you with the San Francisco Unified School District when our collaboration gets a little further along.
And I'd like to, and I'd just like to add that, just some of that work, just to let you know, because like Janine said, we agree. And I think some of the innovative ideas is, we're with our DOJ grant, we were actually able to pay the students, as an incentive to actually join the work study to do an art contest and to coordinate an art contest around anti-vaping and partnering with SF Muni MTA to get their artwork on the buses that they ride, and focus on the lines that go to schools, so they can be proud of that artwork and also just be promoting that message at the youth level. So just wanted to share some of our grant scope of work that we're hoping to be able to share those successes and some of that artwork when it comes back to us in a year's time.
Thank you. And I would really appreciate to, as you said, Janine, to come back and present, because we always like to see the implementation of the wonderful things you're saying, and not that and so that would be very much appreciative by me, and I know our committee to see the end product and as well. So thank you very much, and we would very much look forward, and when you have an idea of when you might have some of that information, our wonderful Mr. Morowitz would, put you on our agenda so we can get your update. Thank you.
Thank you.
Maybe we could have the student come who wins the contest. That would be such a treat.
That'd be great. Yes. They could probably he might be one of the wonderful kids that I see who they have these vape sessions in the parks. So yes, I know. So I appreciate it. I really appreciate your work.
Thank you.
Thanks, Commissioner. Commissioner Chow has a question or questions.
Yes, actually, I had about, I guess, one question, which was just an issue of fact, is has the FDA actually approved already any of the vaping options or instruments? Because I actually haven't kept up with that. And I guess the second is that, we were criticized that if we put these bans in, people will just go across the county line anyway and continue to use them. And therefore, your educational efforts really to change behavior is really the answer than just simply not having it available. But do you know that while you have reduced the number of flavored tobacco items by about 80–90%, that we've actually reduced the use of flavored tobacco in the city and particularly amongst the youth?
Okay, thank
Um,
you.
Yeah, do you want to answer the e-cigarette where the number of approved?
Yes, so for the e-cigarettes, the FDA has been approving the devices and some of the products. What in our efforts of being transparent and supporting our businesses, when you can go to our website and there is a link that will give people directly to the FDA approved list. So currently, there's about 3 products that we know of that can be sold in San Francisco at this time.
Okay. Oh, no, thank you. Is Juul one of the products?
No, Juul has not been approved yet, to our knowledge, not yet.
Could you answer the other? I know that your survey was 2019 data that was published just I guess as a 2021 report. Can one look back to a different time? Although flavored tobacco just sort of came out the few years before that, but is there any comparison to know whether or not that's lower or higher, or does that become sort of a baseline that we're working with?
That is a good question.
I think it's a baseline that we're working with. Yeah, they were too close because our law went into effect in 2018, but it actually wasn't implemented nor enforced until 2019. So we have this kind of overlapping year. So we can't, I think that we're going to be interested in seeing the next report because that will be, I think, showing what's happening. And then we'll have 2 years of our efforts of educating the retailers, getting it off the shelves, and then seeing if that made a difference. But that's how I understand it.
Yeah, no, very good. No, thank you.
Going across the county to get their vape products.
Sure. No, thank you very much.
Thank you very much, Ms. Young. And I don't see any other hands for questions, so I believe we can move on. Commissioners, let's go to the minutes, which was item 2 on the agenda. That was for the December 21st, 2021 meeting.
I move to approve the minutes.
I'll second that.
Great. I'll ask folks on the public comment line if you'd like to make comment on the minutes of December 21st. Please let us know by pressing *3. All right, I don't see any hands, so I will do a roll call vote. Commissioner Chung,
Yes.
Commissioner Chow,
Yes.
and Commissioner Dorado.
Yes.
Oh, great. The minutes are approved. But we can move on to item 5, which is emerging issues. Any comments or anything, commissioners? Folks on the line, would you like to make a comment on emerging issues number 5? Press *3 now. No hands. Item 6 is public comment. Folks on the line, if you'd like to make comment about anything that's not on the agenda, this is the time to do so. Please press *3. All right, no hands again. So commissioners, you are now at a consideration for adjournment.
I so move to adjourn the meeting.
Second.
I will do a roll call vote. Commissioner Gerardo,
Yes.
Commissioner Chung,
Yes.
and Commissioner Chow.
Yes,
All right, thank you all very much. Hope you have a lovely day, and commissioners, I'll see you in a little bit.
thank you.